Good afternoon, everyone. Thank you so much for joining us today. I'm going to give it about a minute more, and then we'll kick off today with our next free webinar series. Again, good afternoon, everyone, and thank you so much for joining us today. I'm Samantha Mokas, and I'm the Director of Member and Partner Services for the Florida Association of ACOs. We are excited for this opportunity to present to you the next installment of our free webinar series, Integrated Behavioral Health and Telehealth under the new CMS Pathways to Success. Before we get started today, I'd like to go over a few items so you know how to participate in today's event. You should see an attendee interface on your computer desktop in the upper right-hand corner. You can listen in via your computer speakers, or if you would prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during this presentation. We will collect these and address them during the question and answer session after today's presentation. With that, I'm going to turn the presentation over to the team at C3 Healthcare RX. Thank you, guys, and you can kick it off.
Sam?
Yes.
Hi. Thank you, Sam, for coordinating this opportunity to speak with your members. And we are very excited to be speaking with you this afternoon. And thank you all for joining us. I am going to go over the agenda. My name is Renee Brown, and I am a pharmacist as well as business development manager here at C3 Healthcare. And I'm going to go over the agenda with you, and then I'll give you a brief background about what we do here at C3 Healthcare RX, and then I'll turn it over to our specialists here, Justin and Scott. And first of all, who is C3 Healthcare? We are all about healthy outcomes. We produce human wellness by connecting personal touch and digital services. And how do we exactly do that? And at the core of our business is our pharmacy services. We were started in 2013 and as a pharmacy. And we really specialize in doing personalized pharmacy services by doing mailing medications to patients in their home. And compliance packaging is one of our key components to that adherence. We also do some of our newer services are our Mind Healthy and behavioral health assessments. Justin is going to talk in more detail about that, so I will just let you.
And the other services is Scott Allen. I'm going to step in here. We do in-home med management for hospital and ACO partners to reduce readmissions into hospitals. And as Renee was saying, we have a very nice pharmacy, kind of a concierge pharmacy service, which includes some in-home tele tools that we have now. We do reconciliation, we do synchronization, and as she said, very importantly, we do compliance packaging with easy tear-away dosage, very easy for clients and customers. So just a general overview of what we do, but right now I think I'm going to hand it over to Justin, and Justin's going to talk about integrated behavioral health.
All right. Good afternoon, everyone. So just a bit of background about me. I have been in chronic care management with some large companies for about the past 10 years. I've worked with DaVita and managed folks with chronic kidney disease and obviously multiple other chronic conditions, and most recently with Landmark Health, who is known for being an innovative home-based care company, primary care supporter, and is really known for their innovative approach and interdisciplinary approach to care. They are a shared savings operating under a risk-based model company. And so a little bit about why behavioral health, and I'm saying things that I know most of us already know, but it's just worth going over the numbers. And so, over 40% of patients that we see in primary care settings have mental illness. 80% of those that present have behavioral health issues present in our ED departments very frequently. There's a myriad of other metrics that are not listed here, but that are important to chronic care management. And that number, as we all know, is higher for the Medicare and Medicaid population. Okay, and so, just a little bit more about integrated care, and specifically as it applies to behavioral health. So we know that this Medicare Medicaid population is presenting in the emergency room at a very high rate, but integrated care is something that's pretty hard to capture in the short time of a primary care visit or an emergency department. And so integrated care really gives the opportunity to address mental health issues in a very kind of cost-effective and efficient approach that's patient-centered. And I know that sounds very high level, but I'll go into details as to what that means a little bit further. But efficiency and using the tools that we have today to really address the patient kind of where they are is the key to integrated care. And there's some really kind of unique ways that that's being done today. Okay, a bit more about why integrated behavioral health care. So increasing access to behavioral health is key. So quite often we're doing minimal screens either in a primary care office or in an emergency room, and they are often not happening consistently and not in a way that has significant follow-up or that we can track on a consistent basis. And so really increasing access to not only behavioral health care, but just the screenings that allow us to know what issues we're dealing with. Behavioral health care also, as integrated into a primary care setting, improves outcomes. And as we're here talking as accountable care organizations and value-based care, there's more to the bottom line than just addressing the physical outcomes, and we know how significant the mental health impacts the chronic condition care as well. And then the last piece, reducing overall healthcare costs. We covered some of those key metrics at the beginning, but we want to go into a little bit more detail as to why behavioral health care impacts our utilization in hospitals and primary care as well, and what we can do about those things. And so as we talk about integrated behavioral health, particularly as it pertains to an ACO, we know these core metrics under the quadruple aim are what we have to focus on. And as we talk about improving population health, integrated care is really structured in a way that you measure population health. It's a measurement-based program, and we want to talk a bit more about what causes, how we're able to do that measurement-based screening on a consistent basis, and overall improving patient satisfaction as well. And I think this integrated care model, really the key to it is about convenience and helping to extend kind of a bridge towards patients to addressing care and meeting them a bit more where they are than we're able to in the past. And so we'll talk about that. What follows with that is a cost reduction and improved patient experience as well. Okay, and so this goes into a bit more of what we covered already, but that identification and screening is really key. There's some very key organizations like the VA that have really integrated doing behavioral health screenings in some facilities for all primary care patients prior to an appointment. And we'll talk about some quotes later on that there's some very significant healthcare leaders that recommend behavioral health screening be a part of every patient visit. And we know that there is such a huge link to being able to identify mental health, behavioral health issues, social determinants that impact the rest of these areas that we're dealing with, like hospitalizations and improving outcomes more on a chronic condition or physical condition basis. I will give an example. We've spent some time implementing a automated screening tool for behavioral health in some primary care physician practices, and you'll often hear a patient get really touched and say, I had no idea I was going to have this level of conversation when I came in, but it just opened up the door for not just a conversation about mental or behavioral health, but about social determinants, transportation, family issues, all the things that we know significantly impact the care and the decision-making ability of our patient that's desperately needed for them to manage their own care. All right. So how would one get started with a behavioral health integration if they wanted to? There's some very key resources out there to do that. There's been a lot of research done on behavioral health integration. There's about 30 years of research data on behavioral health integration that's being used right now to drive kind of the recommendations from CMS on how a primary care office or practice or ACO should roll out behavioral health integration. And so, again, we'll talk a bit more about a lot of other resources. This is one from the AHRQ on behavioral health integration specifically for primary care, but there are a lot of these. We have a list later on in the presentation that will address it further, but just wanted to share there's a lot of resources that exist already on how to do this. Okay, and so what is the goal for getting started? One piece that we would want to start with is, where you are today. Where do you stand in terms of this kind of continuum of care? And so we have a model that has always been that we know kind of will not work today in today's healthcare landscape that's value-based care and really outcomes-driven. And that's the one of coordination, which is, a typical example of a member or a patient coming into your office and, maybe having a behavioral health issue, and you either do a medication management solution yourself or you do a referral to a psychiatrist or counselor. And quite often we know that the rate of actual attending a referral to a psychiatrist or psychologist or behavioral health specialist is very low. And so the care goes unmet and that cycle kind of continues. The person does not really get quite the care that they need, and they represent back into your facility. The second option is of co-location. And this is an example of having a behavioral health person that you hire and they're right within your office. And this is a great solution. Obviously, if you can make this work, it's a fantastic option. It provides convenience to patients. You can address their needs right within one appointment, and you can have kind of a care collaboration team right there. The cons to this option, though, are it's somewhat expensive if you have to hire the staff on your own, and it's just not feasible for a lot of providers to be able to hire a staff that can be co-located in their facility, and it's a little bit more difficult to implement as well. But the last piece of where this integrated care model gets to is a integrated care approach that really is efficient and allows you to implement an interdisciplinary care team specifically for behavioral health without necessarily having to hire someone on your own or bring them into your own office. It really utilizes technology and tools, and we'll talk a bit more about an online registry and collaboration platform that allows someone like a psychiatrist consultant to allow the PCP to still be the primary driver of their patient's care in that relationship, but enables them to have an opportunity to consult with a professional on that care plan as it pertains to behavioral health. And then there are additional opportunities like telepsychiatry, which still gives you that same virtual visit that a co-location would, but without all of the overhead or upfront capital costs that it might require to have a person specifically in your facility. Okay, now as we talked about behavioral health integration, there are really some key components to making it work, and all of these metrics are driven, as I mentioned earlier, by kind of evidence-based studies over the past 30 years, and this guidance comes from CMS and has trickled down across the states as well. And really, it's a person-centered approach. As we mentioned, we have to look at patients more as customers today if we're really going to address the care that they need. And if the traditional model doesn't work, what else can we do? And it's about adding convenience, especially as it pertains to behavioral health. So as we know, it takes it is hard enough to get patients into the office for their primary appointments, then it can take very small barriers to keep someone from going to a referral. So, oh, it's rainy outside, or I don't have transportation. And so that additional appointment really can make a hindrance for them getting the care they need. And so how do we make it more convenient? And so patient-centered approach is one piece. This population-based care, being able to actually not just assess patients on kind of a one-on-one basis, but looking at your entire population. You probably will ask, how do you do this on a effective basis? And there's some really good tools out there that allow you to have a registry of just for behavioral health for your patients, and you can track it, and that ensures no one falls through the cracks. And it also gives you the platform to be able to report out on the key metrics you need on an ongoing basis. And that kind of leads to this next one on measurement-based treatment. So the only way under this value-based care to really move the needle is to be able to measure your progress and report out on your outcomes. And there's some very consistent ways and recommendations from CMS on how to do this. And we'll talk a bit more about that later as well. And the last piece, we have to be efficient, right? Under this model, we don't have a lot of opportunity or resources for things that aren't effective. And so using care practices that are evidence-based are key to this as well. And accountable care is the last piece, which we're all very familiar with, that we're going to be held accountable to the care that we provide, and the top metrics above that provide the way to do that. All right, and so if we haven't convinced you yet that behavioral health integration might be a really good option, that this kind of leads into, if you do agree that it is, how would you actually implement it from more of a softer or team approach? And there are some pretty key pieces to that as well. As with any change management, which this would be, requires some change to workflow, not significant, but it would, to be able to integrate behavioral health solution. And so it really would start with leadership, really making it clear from the top that behavioral health is more of a core part of the model of care than a secondary piece of model of care that's seen in the past. So unfortunately, we've seen physicians' offices, and we'll talk to a PCP and go in and integrate, build a plan to integrate behavioral health into their facilities, and the primary care physician is very excited and ready to go, but the staff just doesn't quite get the importance of it. And if that communication doesn't trickle down, the process and the workflow doesn't work well. So that leads to the next one, is it really takes a full team buy-in, and that starts from the top, and that takes a bit of training as well. But again, there are some very good processes out there already on this. There are organizations that have done this time and time again, and it's not a new model. It's just one that has been proven to be effective now, and as we highlight, behavioral health is so important, it's really being implemented at this time. And so that team-based approach is pretty significant, being able to identify the right roles of who's going to do what. And the last piece to this is ongoing continuous improvement and evaluation. So when you do an integration of any sort, I'm sure EHRs, for example, are one that most of us are familiar with. That it's not going to be perfect at first, but just being very clear that that's not going to be the case, and it will take a bit of refinement for your specific workflow, your specific office to get it right. But a promise that the return on investment will be well worth it. Okay, and so we went over this kind of integrated behavioral health care at a high level, and there are actually several models out there of how to integrate behavioral health. But I've chosen, and not only I, but CMS has chosen this collaborative care model as the primary model of choice. This one, after that 30 years of research that I mentioned, has in particular been proven to be cost effective and show real outcomes. And so this one's kind of selected by CMS, Medicaid and Medicare, and which is why it's reimbursed by Medicare and Medicaid as well. And so it's proven to show the outcomes that we talked about already, including patient satisfaction, health outcomes, and then helping people function with their current behavioral health conditions, but also identifying social determinants of care, which we know are so key. Okay, so now for the really good part and the meat. What is the collaborative care model? And so it really takes several components. The core, as I mentioned early on, is to keep the primary care practitioner as the key driver of care, including behavioral health. And so it's built to enable the primary care practitioner to do it efficiently, cost-effective, and in a way that drives real results for their patients. And so this is done by adding a few key components. And so we talked about that interdisciplinary care team. You know, you may have this on some level or to some degree. This is where a little bit more assessment would go in to that. But the key components are a psychiatrist who is a consultant. So they can be in your area, or they don't have to typically be co-located, and quite often they're not co-located. Then a behavioral health care manager, and a technology piece, which is a collaboration platform. And so under this model, a patient would come in, they might, express depression, anxiety, and you would be able to address that through doing your screenings, which this collaboration platform in many cases allows you to do that in an automated way, and so you get real-time results and you can discuss it right in the same appointment with the patient. And then you're able to have that care plan reviewed by a psychiatrist, that psychiatric consultant. That piece is also enabled through that collaboration platform. That the other piece that we'll go over is this behavioral care manager. And so there are all those pieces of kind of just ongoing collaboration to ensure that a care plan is followed up on for behavioral health care, and that behavioral health care manager is able to do that and assures everyone is able to work at the top of their license, and you're not overutilizing a psychiatrist resource outside of that need. And then the last component of this is that collaboration platform, which I've mentioned a few times, but I haven't really explained what it is. And so collaboration platform, or also known as an online registry, is a component of technology that's added to this that also is required, but really has validated rating scales included so that you're assessing the patient on depression, anxiety, traumatic stress, or substance abuse, and you're getting the clinically validated results. And then it allows you to also document a care plan. In some cases, if that platform is really good, it generates an automated care plan for you as a baseline. And then it gives you a tool to do online continuous tracking, progress tracking. And so often those screens are represented every 30 days so that you can continuously monitor progress. And then the collaboration piece also is included in that it gives you the opportunity for the site consult, the behavioral health care manager, and the primary care provider to coordinate virtually through notes through this platform as well. And it's all housed and documented in one place. Okay, now we talked about behavioral health integration very much from a value-based standpoint to this point, which is definitely enough of a reason. But there is significant reimbursement on a fee-for-service basis for implementing the collaborative care model. And this is specific to that psychiatric collaborative care model formula for behavioral health integration. And as you can see in this, the reimbursement amounts are significant. And so there's an initial just for doing kind of the first month of assessments and building out a care plan for your patient, but there's ongoing reimbursement as well. So if a patient has ongoing care needs and they're on a cognitive behavioral care plan and they're progressing through it, there's a monthly reimbursement for that collaboration with the site consult, the behavioral health care manager, and using that online registry as well. And the last point that I would make about this slide is that there are significant calculators out there as well. So this has been implemented in many primary care practices and looked at from a P&L standpoint to ensure there's profitability. And we've included some of those resources as well, so you can take a look and really figure out from a nuts and bolts standpoint if it would work for your practice from a financial resource. All right, and so as we talk about revenue for integrating behavioral health, these are some of the key data points that you would want to consider. Capacity. So what's the percentage of face-to-face time you spend with patients today versus what you may be able to if you are able to shift some of the behavioral health concerns to someone like a psychiatric consultant or behavioral health care manager? Would that enable you to see more patients? Productivity. And so there's often a productivity increase outside of doing referrals and medication management when you're able to shift some of those to your behavioral health kind of care team on the back end. And so what else could you be able to do with those resources? And then the reimbursement, which we already discussed, that there's a significant reimbursement for behavioral health services for this collaborative care approach. The last piece is just looking at, average cost of behavioral health care from a network standpoint for your practice or facility, and how that might change under a collaborative care model. Okay, and so just to kind of drive it home, there are pretty significant reasons that behavioral health integration make a lot of sense from a value standpoint, and you can look at it from a revenue standpoint or also from a quality standpoint. Either way, there are significant opportunities to drive productivity within your facility, increase outcomes across your ACO, and reduce healthcare costs. And then the last piece, which is goes without saying, is this is about the patient. So we're really trying to address a need that's not being met today. So behavioral health is identified as such a huge problem, and we know where the patients are. They're in the primary care facility or an emergency department. And what we're trying to do now is find out how to effectively and efficiently treat them. All right, and as I mentioned, there are significant resources out there to really help you determine where you are in that continuum of behavioral health care and how to assess and how to get started. And so we've listed some of those here, and will be part of your presentation that could help as you implement. The one point that's really key to this one is, while there are a lot of resources, I know a lot of us have limited time as well. There are significant partners or consultants companies that consult directly to do this with you. I know one that I could mention as well, which is C3 Healthcare. And so, to give a shameless plug, we integrate with primary care physicians and ACOs every day to be able to build the technology piece and that psychiatric care team they need to be empowered to address this in a better way. All right, so I will just kind of leave this slide as a takeaway for you. Really, we just wanted to list some of the steps to consider as you're thinking about clinical integration for behavioral health into your facility. Where are you today? So we'll continue, but we wanted to include this for you as you review it. And one piece that I just wanted to leave with is, this is from Dr. Amandani at Henry Ford Health Center. They mentioned that they believe mental health conditions are widely underdiagnosed, and we need to include behavioral health screenings basically in all of our programs. And that's just such a significant and key direction that our country is going, and just thought it was summed up very well there to share. So takeaway, behavioral health in primary care setting makes great sense, not only from quality standpoint, but from an ROI standpoint. It's the right thing to do. And there's some really key ways to do it. And I think we would love to help connect you with the right resources. And I'm going to turn it over to Scott here in a second. And, really one of the efficiency pieces that we didn't talk about is telepsychiatry and how that's impacting this collaborative care model and creating that efficiency. So I'll turn it over to Scott.
Thank you, Justin. You did a good job. That's a lot of information, and I know that the collaborative care model is really going to take off over the next few months because it's really a needed program. As you may have seen in my bio, I'm actually a technology person working in healthcare, but I'm really trying to become much more of a healthcare person that knows a little bit about technology. My background is mainly in video production, video compression, all kinds of technical stuff, mostly with Sony Corporation. And then a few years back, I started a telehealth company and built a software platform that we offer. And then we started integrating with other companies and platforms, and that included C3 Healthcare's, some of their concierge pharmacy services that they integrated our telehealth platform into, as well as the collaborative care product. And so it just made sense for C3 to acquire our company, and I'm super glad to be here. And it's kind of a lot of fun to have numerous product lines to go forward with customers. But I'm going to focus right now really quickly on, telehealth and telemedicine. So telemedicine is kind of where we've been in the past, the big carts going around the hospitals and having tools like blood pressure cuffs, but basically the idea of a doctor being in one facility and a patient's in another, and they're able to give them an exam remotely. Telehealth is a much more broader, kind of a expansive modality, let's just put it that way. Clinical, non-clinical, you can do virtual intakes, and you can also do quite a bit of behavioral health care where you really don't need to lay your hands on someone or need to measure them with any type of a device, but just really try to replicate that person-to-person discussion and examination as best you can. And again, we started with the goal of trying to mimic that in-person, face-to-face as much as possible, especially in behavioral health care, because you really need to be able to not just hear and see what that person's saying, but you really need to hear and see what they're not saying. So what do we currently face as a provider in terms of in terms of where we're at? Well, we have a critical shortage of particular types of clinical resources, and that whether it goes to a dermatologist on the primary care side or any type of specialist, or certainly psychiatric and nurse practitioners on the mental behavioral health side. So telehealth kind of can help that out. There's always been and always will be weather-related or economically related geographic and transportation issues, both on the provider and the patient side. Technology challenges. Connectivity can be expensive, broadband can be expensive, and especially in the old type of telemedicine where you had to have these dedicated T1 lines and Gig-E lines, and that's getting better and we'll talk about that a little bit later. And in the past, the hardware's always been kind of bulky and very expensive to implement at each of your facilities. And of course, reimbursement concerns has been probably the biggest obstacle, and as you'll hear a little bit later, those obstacles are going away. And I think canceled appointments, doesn't matter if you're primary care, mental behavior, auto mechanic, cancellations will kill you. But I don't think people really put numbers with that. So the idea of being able to mitigate some of these cancellations could really just increase the overall bottom line, as well as provide the care that's needed. So in one practice that I went and met in Greensboro, North Carolina, I asked the CEO, so how many clinicians do you have? 10. How many cancellations a day do you think you have? Well, we have that number, and the average is about 1, sometimes 2. They got $85 for every session, and that rolled up to $17,000 a month. That was really in a lost opportunity. So the ability to connect with those patients via telehealth to mitigate some of those really was a great value to them. Even if it was just as much as 30%, you're still looking at a pretty good number in terms of about $5,500. So obviously the benefits of telehealth services, adding them to your practice. You're going to increase revenue by mitigating cancellations. No matter what percentage you can actually recoup, you're going to increase revenue. You obviously will have increased clinical efficiencies. If I've used this example because we were at a hospital locally, and it was about a 15-minute walk from the heart surgery department down to the emergency department. And a lot of times someone will come in and present, and they'll have that specialist come all the way down to the emergency room. And with the telehealth platform that we put in, they are able to connect. Hey, doc, this is what's going on. Do you need to come down here? And they could make that decision instead of spending all that time going back. Just something as simple as that. Obviously, increased geographical reach for certain practices. Going into rural areas, you can really kind of expand your practice reach. Of course, this one is not really thought of much, but if you could have a telehealth visit with a patient as far as a follow-up goes, post-surgery, post-acute, something like that, in their home, that would actually make it so they didn't have to come back to a hospital or a waiting room where there are a lot of sick people and germs. And I think overall, as an ACO, you'd probably want that benefit of not having that person be exposed or frankly having all the other people exposed to what might be wrong with that person. And then just convenience. When it comes right down to it, telehealth is really all about efficiencies on the provider side and convenience on the patient side. So big news. I'm not going to read this, but the bottom line is the way they were paying and the way they're going to pay is changing completely. And it's going to start January 1st, 2020. And as you can see this highlight, it says, what this basically says is people don't have to be in a facility anymore to get reimbursed by Medicaid and Medicare for telehealth services. They're going to take down the originating site requirements, and now, if you're a member of an ACO, you will be able to charge your services even when your patient is at home. It's a giant paradigm shift in the CMS. So moving along here, I'm going to talk a little bit about what you would look for in a telehealth service. Cloud-based, I think, is key for a number of reasons. Security being one of the biggest reasons. Accessibility is another reason. But one of the four keys to HIPAA compliance is obviously physical security. So you have to lock down your devices and you have to lock down your servers. And when things are in the cloud and you basically just do everything from a web services standpoint, it doesn't matter if you lose your cell phone. You don't have to have a server on site that has locks and security people. And that's a big, big plus. You obviously want an easy workflow as much as possible. You want it as easy on your patients to get into and out of a video session, creating a session. So workflow is really key. Some of the platforms out there, it's as easy as getting a text now on your phone, and you can actually click to open a text, and there you are, joined with your provider. It's super easy, and not everyone has a tablet or a PC, but almost everyone has a phone, and not everybody gets their email on their phone, but almost everybody gets a text. Central administration, the idea of keeping your very expensive clinicians and clinical staff just to doing clinical things rather than administrative, setting up appointments or anything like that. So if you can have a platform that allows for an administrator to go and set up sessions and all the provider has to do is click one button and join the session, that's a real key. And last, I mentioned this earlier, I'm a video person. High definition video and audio is really important when you're doing any type of telehealth, whether it's mental behavioral, primary. The ability to actually see a skin condition or to really, like I said earlier, read a person's emotions is key. And most people think about a Skype or a FaceTime sort of a video image and that type of compression. And that just doesn't, when you have choppy audio and video, it doesn't make for any type of great healthcare delivery. So primary care clinical uses, I mean, I'm not going to go through all of these, but there's a lot. Pretty much anything you can do face-to-face, unless you require laying your hands on someone, you're going to be able to actually go and do follow-ups and use telehealth for these types of visits. And certainly follow-ups are huge. So billing, I think I said earlier, these are the current rules of engagement for billing for telehealth services. If a person is in a hospital and if a clinician's in one facility at the hospital and a patient comes in another, and they can connect through telehealth, as long as those originating sites fall under those bullets of qualified originating sites, you're good. And then the distant or hub site is actually where the provider is. So right now, in order to get paid, you have to have an originating site, which is where the patient is, and a distant or hub site, which is where the provider is. And as long as you meet those, they'll pay you. Going forward, distant site practitioners today. And I don't see this changing very rapidly, but right now, in order to get reimbursed by CMS, you have to fall into one of these licensures. So physicians, NPs, PAs, all the way down the list, clinical social workers. And in some, we in North Carolina, we have to have Psych Ds, but this is a pretty standard Medicaid, Medicare list of who qualifies to be paid for telehealth services. Now, as far as codes go, I think you're all going to have the distribution possibility of this deck. We've actually put a link in here to this the CMS Telehealth Services booklet, but there are right on 100 codes for telehealth services, and it's actually a great booklet. As far as where we're going with telehealth, I put a couple of articles. We get them every day, but there was one that interested me quite a bit as a telehealth person. But basically, the article on the top said that individuals are moving away from providers who don't offer a telehealth service. I think Teladoc has done just a tremendous job of kind of clearing the way for the modality of being able to pick up your phone and talk to a doctor remotely. And that's great unless you're an ACO and you want those patients to stay within your care coordination so that you can really track that population. It only takes one patient in your organization to go out to a random Teladoc doctor and somehow or another get a misdiagnosis because they're not getting the history, and that just opens up an entire sort of a can of worms. So having your own telehealth option as your patient, I think, is going to be more and more critical as things go forward. And with this new CMS pay structure, telehealth is just going to explode over the next 5 to 6 years. And I'm going to kind of leave this fun fact with you. In 2017, 0.25% of all sessions between a doctor and a patient under Medicare payment, 0.25% were done via telehealth. That represented about $30 million in billing. And to put that in perspective, the overall spend was at $1 trillion. So it's kind of a rounding error. It's just a ridiculous amount. So 99.75% were done face-to-face. And if you look at this and you just were to take it away as Medicare, obviously this is global, but that doesn't even hit 13% of those visits to get to that $130 billion. So telehealth is coming, and there's some reasons why. Mostly because the technology is better, it's less expensive, the video quality is better, and obviously now billing legislation is really working for and towards telehealth as a verified modality to deliver care. And then I guess the last thing to say is, as an ACO provider, given that January 1st, 2020 is going to be here before we know it, as will July 1st, I think now would be a good time, if you've not already done so, to start looking at telehealth platforms. So with that, I'm done. And Sam, I'm going to push it back to you to have some question and answers. I appreciate everyone's time.
Thank you, all three of you, for that great presentation. I do have a few questions here today. So we'll start with, what are the main components and advantages of using a collaborative care platform?
Yeah, this is Justin, and I will take that. And so under the collaborative care model, there are just those essential components we talked about that are required. That's a psychiatrist consultant, a behavioral health care manager, and a collaboration platform. And so the pieces under that collaboration platform include assessments. And so one, being able to do clinically validated assessments to get a baseline, and then be able to do those on an ongoing basis so you can measure over time. And so having the ability to assess every 30 days on an automated basis. So it's not paper, you're not converting, but you're able to report out all your metrics. Second piece is an online registry. And so that's a specific term by CMS, and that is basically a composite or a housing of the care plan that is provided for all of the patients, but at a population level. And so it gives the opportunity for multiple entities and stakeholders to log in and view the care plan and to to collaborate on it as well. I think the last component, which would be a plus, is one that already provides some form of care plan built in, so some automation there based on the patient results and answers, that it does some form of automation kind of to give a bit of a protocol to go off of as a starting point for the behavioral health care plan.
Thank you for that. So the next question I have is, if I want to implement collaborative care model in my practice, what role can telehealth play to enhance engagement?
I'll take that one. For collaborative care, it's all about having, and most of the ACOs that we work with don't have psychiatric services or psychiatric consultants available to them. So filling all those gaps is important, and how you fill them is a differentiator. So a combination of the collaborative platform using telehealth is very efficient, because each of the PCP, the care coordinator, and the nurse practitioner or psych consultant can all go onto the platform, view the care plan, agree on the care plan, and then the psych consultant can actually telehealth into the doctor or the care manager to provide what prescription they advise or what type of treatment plan going forward they'd like to see. And face-to-face communication, whether it's in person or via tele, is more, it's more effective than just simply a phone call. Not that the CMS they don't require it be telehealth, but I think having that engagement and that personal kind of communication using telehealth between provider to provider and even provider to patient where it might be needed, it just adds a lot more value. So the combination of it's all about the patient, it's all about care, and when a patient can see a person that's providing a care plan for them, I think it's just much more effective with telehealth.
Yeah, and if I could add just to that one a little bit too, Scott, is the telepsychiatry piece. And so what we've seen and has been reported as, we want to be efficient and make sure we're all using technology as best possible. And what's been most widely accepted so far by patients is telepsychiatry, because, it's an easy next step, from doing a face-to-face visit to doing a telepsychiatry visit. It's almost the same thing. It's just virtual, and it kind of replaces that co-location issue of having to have a behavioral health person there. You can schedule appointments virtually and have a patient do it right within a visit to the PCP.
Thank you for that. And the last question I have today for you is, what ACOs does C3 currently work with, and can you provide some examples of data of positive outcomes?
Sure, and I'll be glad to answer that one, Sam. Some of our partners in ACOs and hospital systems, we work with CV CHIP out of Virginia. We work with P3N in California. Someone local here in North Carolina is Triad Healthcare Network, based out of Greenville. Central Florida Health System, and some of our larger payers have been United Healthcare and Aetna, and one of our first clients was VCU Health System in Virginia, and we've had significant programs and results with them. Some of the results we've had is an overall readmission reduction rates of an average of 25% lower than our clients' hospital baseline rates, and also with our medication management and in-home visits, we've been able to reduce medication errors, approximately about 40% of home visits, and it's reducing costs as well as synchronizing patients' medications. And then our pharmacy error rates are significantly lower. Retail average pharmacy error rates are average about 2 to 3%, and C3's error rate has been less than 0.3% since our inception.
Thank you for that. I appreciate that. I have no other questions today. So with that, I would like to thank you all for participating in this event, and especially to C3 Healthcare for presenting to us. We'll be sending an email with contact information. So if you have any follow-up questions, please feel free to reach out to me, and I can always direct you to the C3 team. A link of the webinar will also be coming as well, so please feel free to share that link with anyone you may think may be interested. Also, I would like to remind everybody that we did officially announce the FACOS Fall Conference. It will be taking place November 7th and 8th in Orlando. We'll be releasing more information in months to come. I want to thank everyone again for your time and have a great day. Thank you all.
Thanks, Sam.
Thank you.